It is also, I want to thank Gaur for organizing these and for Zydus to support it, because it's such a fantastic opportunity, not just to come and talk about a disease that we're all very passionate about, but also, an opportunity to meet with professors like Dr. Sharma, who had such a big influence on all our lives, many of our lives, and then also catch up with old colleagues. So, this is the 8th year, and it's always a little challenging to come up with topics. And so what I thought I would do this year is really look at some clinical issues through a different lens. And this is through the lens of the life cycle. So here are my disclosures. And I am an unashamed liver lover. Okay. So if you're a classical... Uh-oh. Does this count against my time? Okay. So if you are a classical hepatologist, your idea of this disease is that you have MASLD or MASH, you get fibrosis, you get cirrhosis, you get outcomes, and then you either get a transplant or you die. Now, maybe I'll present a different view. This is a chronic disease that occurs at all points in life, from conception through early childhood, adulthood, old age, and death. Now, at each of these phases of our lives, we have different physiology, different metabolic milieu and comorbidities. We have different behavioral aspects and different needs and priorities. So let's look at this disease through the lens of what happens and the needs and the biology at different points in life. Starting right at conception, it turns out that those patients, if you look at stillborn children, particularly of diabetic mothers, the proportion with hepatic steatosis is dramatically higher than those who do not have diabetic mothers. So there is immediately right at birth, the ability to actually survive, to be actually born, gets impacted. In childhood, if you are born, there's the issue of physical growth, intellectual development, mental and social development. So there are many other things, but I'm going to just talk about these right now as key factors that are unique about the childhood experience. So if you look at birth weight, and you look at those with low birth weight, normal birth weight, or high birth weight, both babies born with a low birth weight and a high birth weight, they are more likely to develop MASLD. So the proportion of kids with low birth weight and the proportion of kids with high birth weight who have MASLD, in both the MASLD is overrepresented. Now, if you look at the right in the table, what you see is those with a high birth rate, the odds ratio for steatosis is much higher than those with low birth rate. But if you look at advanced fibrosis, the odds ratio for those with low birth weight is higher, quite a bit higher than those who are born with high birth weight. So there are clearly different physiological adaptive mechanisms that set you up for different trajectories of the disease, even though the disease is going to develop later in life. But right at birth, at the weight at which you are born and the catch-up weight, this sets your metabolic machinery for issues down the road. The other issue is intellectual and neurological development. Now, this is just an overall thematic that we published some years ago, but essentially there are signals from the gut, muscle, and adipose tissue, which lead to release of cytokines, hormones, diet-related products, autonomic inputs. And then there are inputs from the liver when the liver gets steatotic. All of these converge on the brain, and the brain is bathed with all of these products that impacts, based on your genetic, the neurocircuitry and neuroinflammatory responses that are the biological underpinning of depression, anxiety, etc., and also various types of behaviors, such as your eating behavior and your ability to comply with lifestyle and diet. So there is a complex interplay of biology that gets set up very early in life. And this is really a very nice study that was published in Clinical Endocrinology and Metabolism, which shows that people with MASLD have poorer scores for short-term as well as long-term memory. And this is associated with a decrease in hippocampal size, and particularly there's also decreased presubiculum and subiculum volume. And this is also, particularly if you have ballooning, hepatocellular ballooning actually correlated really nicely with poor neurocognitive development. So there is a linkage, at least statistically, connecting the dots between the hepatic steatosis and the brain development. Now, as the child gets older, what we now find is that kids with hepatic steatosis are at more risk for developing depression, suicidal tendencies, and those with elevated ALT are more at risk. And this again goes back to this issue of neuroinflammation driving depression and anxiety and many of these behavioral disorders. Neuroinflammation because of the inflammatory cytokines not only coming from everywhere else in the body, but also from the liver. Now, these are early days. This is an emerging space, and we need more data on the impact of stress on hormonal development, impact of drug abuse, which occurs in teenage years, impact on academic development, and very importantly, this growing problem of suicide among teenagers throughout the world, and which has now been linked to obesity and systemic inflammation, but now increasingly data also in the MASLD space. So unfortunately, there are still limited data on mental health in the MASLD populations. There are a handful, but all of them show that you have more depression, more anxiety, more social isolation, all of the things that are not good for optimal mental health in these populations. Now, when you move into adulthood, your physical health is linked to your ability to get work, to be gainfully employed, start a family, and so is mental health. And of course, reproductive health, particularly for women, is a very, very important aspect of their adult life. So if you look at depression and NAFLD, these are basically data from the National Health and Nutrition Survey in the US, substantially overrepresented in people who have fat in the liver, even after adjusting for age, gender, race, education, etc., etc. Now about the important issue of pregnancy and starting a new family, which is so central to everybody's personal existence as a human being. Let's exemplify with a little case. It's a young lady who comes in, has been obese since childhood, recently was told pre-diabetic. She's been trying to get pregnant for 4 years, but her menstrual cycles are irregular, short. During workup, she was found to have a little elevated liver enzymes and an echogenic liver. She gets referred to you. You see the CAP is 296, LSM is 11, FIB4 is 1.6. So these are above the usual thresholds that we look at. But she is not interested in her fibrosis stage, I can promise you that. This is a real patient in my clinic. Her questions to me are, what's going on in my liver? Is this why I'm not getting pregnant? Will I never be able to have children because of this? Can you fix my liver so I can become pregnant? And of course I added, because you're an Indian audience, so I threw in, will yoga help? That was not a real question to me. But you see, the patient's perspective of what they think is important is quite different, because I, as a hepatologist, am ready to immediately say, liver stiffness of 11. Let me tell you what liver stiffness is about fibrosis, and fibrosis stage, she couldn't care less. So we have to think differently as caregivers to these patients about what is it they have come to us for, so we can meet the demand for service. So I promise you, this is the only slide with biology in it, which shows the movement of cholesterol into pregnenolone and progesterone, and then through androstenediol to testosterone and estrone. So the key things to remember, estradiol or E2 is the main circulating estrogens and is primarily made in ovarian follicles. Women do make testosterone in adrenals, ovaries, and the liver, and men make estradiol in adipose tissue, okay? So those are the key points to remember. Now, a lot of patients with MASLD have underlying polycystic ovary disease, so many of these patients do struggle with the ability to get pregnant. And it's the most common cause of anovulatory infertility. The prevalence is about 10% in reproductive age and is growing. 40 to 50% have imaging confirmed MASLD. And it's a 2 to 4-fold increase in the prevalence. In those who have MASLD and diabetes, the overall prevalence is increased 2 to 4 folds. So really it is now recognized as an independent risk factor for MASLD. And you can see across multiple strata, the proportion of people with MASLD is quite high. And almost, if you look at on the bars, the PCOS BMI greater than 25, you're seeing almost 75% of these women have MASLD. And PCOS management, in addition to the usual obesity management, people have used metformins, TZDs, DPPs, DPPIs, SGLT2s for the underlying diabetes, vitamin D supplements. Now, what about GLP-1 receptor agonists? How many here would say a patient like this might benefit from a GLP-1? It's an insulin sensitizer, will make her lose weight, will help her get pregnant? Show of hands. Okay, well, here's the data. So GLP-1 receptor agonists, it's pregnancy class C. For semaglutide, pregnancy class has not been assigned. Salcaprosate, which is the drug in semaglutide, can cross placenta in rodents, but unlikely to be in milk at high levels. It does improve insulin resistance. But look at this. I'm a little concerned about this one report with liraglutide, where they reported on 111 pregnancies, but only 47, these are obviously diabetic patients, 47.7% had live births. And there was 28.8% fetal loss, and 5 of the 20 pregnancies were terminated with fetal defects. So I think personally, I would give pause. I need to see more data, more science before there are other drugs on the left-hand side that I might use in this setting. So this patient gets put on metformin and lifestyle management, comes back 6 months later, very happy. Now she's pregnant, she's got her husband, mother, whole family is here in the office. She's 8 weeks pregnant, having a little some morning sickness and pruritus. Now she has a different set of questions in her mind. Can I carry my baby to term? Will this liver problem hurt my baby? How will my baby get this condition? How is my liver doing? Is the liver making me itch? So these are all issues that patients, this is part of that. When you get MASLD at this point in your life, when you're pregnant, these are the things that are most important to you. So we know that the prevalence of MASLD is progressively rising within pregnant population, because it's rising in the general population, it's just reflected in the pregnant population. So we know the relevant physiological changes are insulin resistance, increased caloric intake, increased fat tissue, increased blood volume, cardiac output, decreased immunoinflammation, and high fibrinogen and hypercoagulability. This is normal physiology of pregnancy. In MASLD, the mother gets increased toxemia, HELP, postpartum hemorrhage, and the baby is more likely to be preterm and have, as I already showed you, more likely to be stillborn. So these are the take-home points about how MASLD in the prime reproductive years of our women patients could affect their life. And so some things that we should remember is that there's some additional complications of pregnancy, such as intrahepatic cholestasis. ICP and MASLD, those patients have very high circulating bile acid levels, and particularly they get itching of the palms as an early sign. And MASLD did not impact key outcomes when ICP was present in terms of mode of delivery, gestational age, and maternal complications. If you look at maternal outcomes in pregnancies with liver disease and look at those with NAFLD, MASLD, whatever you want to call it, compared to other chronic liver diseases, you find gestational diabetes, gestational hypertension, toxemia, C-section, postpartum hemorrhage, and maternal death, all overrepresented in women with MASLD. So I think as we think, it's not just about looking at their fibrosis stage and saying take this drug or take that drug. We have to think about these things, about how they are going to impact the patient, and have this conversation with patients who are in that age range where they are trying to start a family. When you talk about their babies, whether it's preterm birth, fetal growth restriction, large for gestational size, and fetal death, you can see that large for gestational size and preterm births are increased in patients with MASLD compared to other chronic liver diseases. So prior to pregnancy, it is really important to optimize medical health, metabolic health. You have to manage the fertility. You have to assess fibrosis severity. If you have advanced fibrosis, remember when your plasma volume expands, particularly in the second trimester, that is when you are at very high risk of variceal hemorrhage. So you have to do EGD ahead of time, band ligate and obliterate the varices, and consider all of those kind of things. Some people have used beta blockers safely, but there is a risk of fetal bradycardia. So those are conversations with high-risk OB that you have to have. And during pregnancy, you have to watch the diet with the calories, reduce the easy sugars, increase proteins, give vitamin D, iron supplements, use common sense for exercise, monitor for complications, but especially varices in the second trimester, and you have to monitor the sugars, weight, fetal growth, and all of the usual things. Remember that pregnancy also puts you, for those who have already advanced fibrosis, there's a 2 to 3% risk of a splenic artery aneurysm rupture in those pregnancies. So those are things to be aware of and to remember. And of course, the long-term effects of maternal metabolic health include not just the mother, but the baby as well, because a lot of these are reflected in the baby. And finally, in old age, issues of frailty, social isolation, and additional comorbidities come up. And it turns out, after accounting for age, gender, education, and all these comorbidities, MASLD is associated with a risk of persistent physical disability with a hazard ratio of 1.4, so almost a 40% increase in this risk. And a lot of it has to also link. We tell people to lose weight rapidly, but when you lose weight rapidly, you also lose bone. And if the patient is already osteoporotic and you make them lose weight very rapidly, you can set them up for a fall and a fracture, which, the hip fracture is an old man's friend. So you don't want that. So you have to be careful in these elderly patients who may be sarcopenic while you're making recommendations about weight loss. And you'll hear a lot more about weight loss through the meeting. And lastly, the issue of hormone replacement for ladies post-menopause. Very poor quality data available in my view. The estrogen levels are generally low. They are mainly E1. E2, remember, is a normal one. And if you give cutaneous, transdermal versus oral, it looks like with oral there's more steatosis in the liver, but I think the quality of the data is very poor. These are all done by ultrasound and looking at echogenic livers, which I'm not sure how good they are. So we really don't have a good handle on this yet. So the key takeaways then are that MASLD occurs at all points in the course of a patient's life. It is important to consider the impact of MASLD on key life-related biological, personal, and social issues, and vice versa. And particularly, it has several adverse effects on women's health. And a proper evaluation of MASLD in women includes a discussion about their reproductive health and a proactive approach to managing metabolic health and MASLD in the context of their plans to start a family. And HRT in postmenopausal women is generally safe, may be beneficial, but we need more data. And older patients require attention to dementia, frailty, depression, and social isolation as disease modifiers. They are not primarily due to the NASH, but these are all things that commonly occur in this population, but they're disease modifiers that may impact outcomes. So with that, I will stop. Thank you for your attention.